Right. Well, good morning, everyone. My name is Darshan Mehta. I'm the Education Director for the Osher Center for Integrative Medicine here at Brigham and Women's Hospital and Harvard Medical School, and also the Medical Director for the Benson Henry Institute for Mind Body Medicine at Massachusetts General Hospital. It's my pleasure to welcome all of you to our Grand Rounds this morning, and we have a really exciting Grand Rounds, and I'll just introduce our speaker in just a moment. But before doing that, I wanted to make sure that all of you are aware of and have registered for our upcoming Integrative Medicine Network Forum. And share. And so, okay, all right. So, all right. Well, again, please do register. This is on November 10th and 11th. The topic of this year's Integrated Medicine Network Forum is the lived experience of depression, an integrative approach. And it's a 2-day conference. CME and CE credits are available. It's free. Our keynote speakers on day 1 is Dr. Vikram Patel, and on day 2 is Dr. Greg Christian. And the whole day is full of really wonderful thought leaders. People are doing innovative work in clinical applications, in research. We will also have patient perspectives on this, cross-cultural perspectives, and an interfaith perspective as well. So this is really an exciting conference and exciting meeting. And really, as you can see, we've garnered the support of multiple entities, and we're really excited to be able to put this on for you. So again, please do join. And it's, again, in my opinion, an event not to be missed. So with that, in addition, on our next Grand Rounds will be the 2nd annual Jack Cogan Lecture, which will be on December 6th, Tuesday, December 6th. It will be at a slightly different time, but you'll get all those details through email at 10:30 in the morning. And our keynote speaker for that Grand Round is Dr. David Rakel. He's the founder and director of the, he's currently chair of family medicine at University of Wisconsin-Madison. And he'll be speaking on doing more, taking less, and living longer. Health is more about what we do than what we take. So again, those details are on the Osher Center website. So with that, it's really my pleasure to introduce my friend and colleague, Dr. Maren Nyer. Dr. Nyer is the Director of Yoga Studies and the Associate Director of the Research Coordinator Program at the MGH-DCRP, the Depression Clinical and Research Program. She is an Assistant Professor of Psychiatry at Harvard Medical School. Her research interests include the treatment of mood disorders and associated symptoms, specifically developing and evaluating innovative, complementary, and integrative treatments for depression. And her talk this morning will focus on hyperthermia, heated yoga, and depression. So with that, I turn over to Maren.
Thank you so much, Darshan, for having me today. Let me pull up my slides. So just a little bit of background. I'm a clinical psychologist at the Depression Clinical and Research Program. I'm going to talk to you today about heated yoga for depression, and we'll also talk a little bit about hyperthermia. I've been at the DCRP, Depression Clinical and Research Program, for about 10 years. And we started an open label study maybe in 2012. And I'm going to present the findings from 2 studies, an open label study of heated yoga for depression, and then a randomized control trial of heated yoga for depression. And before I do that, let me just tell you how I got into it to give you some context. So I was in graduate school getting my PhD in clinical psychology at the University of Virginia. And like any normal graduate student experience, it was very anxiety provoking. So, you know, just the normal sort of graduate school stuff. But in the meantime, I'm learning how to be a therapist. I'm learning how to be in therapy. And the and I believe in therapy. I do therapy almost every day. But my friend dragged me to a heated yoga class in Charlottesville, Virginia. And the first time I went, I laid on the ground for most of the class, and my stomach was pulsing and I was angry. I was like, why is everybody able to do this and I can't? So I went back the next day and I stood up and I started sweating and having this experience and being like, this feels different than anything I'd ever done. And I started going regularly. And with regular practice, I noticed that these graduate school stressors and sort of symptoms that map onto depression pretty well, you know, focus, motivation, sleep, concentration, just stress reactivity, they all started just getting way better. And I was wishing that I could tell my patients about this at the time. And I went into PubMed, which was where I was trained to go look for evidence-based interventions. And there was 2 case reports on heated yoga. So despite the fact that all these heated yoga studios exist around the world, there was no literature on this at all. And one of them was a case report on heated yoga induced seizure from overhydration. And the other one was a psychotic induced episode from heated yoga. So they were just scary looking case reports. So fast forward, I come to MGH to do my clinical internship to get my degree. And I decide to stay. I get serendipitously connected to the chair of our department now, who was not the chair back then, Maurizio Fava. And I knew that I start talking to him about doing a fellowship, and I'm going to do a clinical research fellowship with him at the DCRP. And he introduces me to David Michelin. And David, I don't know why my keys aren't working. These are my mentors on the K23 that we eventually did get funding for. And so Maurizio introduced me to David as my research mentor, and he asked me what I wanted to study. And I started saying something, and he looked at me and he's like, what do you really want to study? And I think he knew that I wasn't passionate about it. And I was like, honestly, if I could do anything, I would study heated yoga for depression. And I had sort of brought it up in grad school, and I got a little bit laughed at, and, you know, kind of good idealistic idea that we're never going to do. And I expected him to laugh. And he didn't even do anything. He didn't say anything. He went to his desk and he got a paper, and he said, I would be delighted to help you to study this. And he said, I'm an acupuncturist, and I've just published this paper on acupuncture for depression. And that was the start of it back in 2010. And I didn't even, at that point, I hadn't even done my research on who he was or that he was this expert on integrative medicine. So I was very fortunate to end up being able to research this just with the team that it was a weaving that was organic. In terms of acknowledgements, we work with a team in MGH. And I should mention Darshan as well. He was a medical monitor for the K23 award, and he is on that publication that hopefully it's under review right now. And these are our external collaborators. You can see we work with people from all over the country. And some of these people we work with on heated yoga research, and some of them whole body hyperthermia. And I'll get into that a little bit as we go. The only disclosure is that the yoga was donated from community yoga studios. And I will show their pictures in a second. And we're very grateful to them. Also grateful to all the participants. This is, like I said, I went the first time and laid on the ground and was totally overwhelmed. There's a real heat acclimation period to exercising in the heat. So I am always, every time I go to a class after I haven't been in a while, I'm always astounded that 80, for these studies, it was like 30 and then 80 people with depression went and tried this out. So big gratitude to them. We have received funding from NCCIH through a loan repayment program and also a K23 award. And this is our center, the Depression Clinical and Research Program. Those are the pictures. That's our website down below. And that's our team up on the left-hand corner. These are the two. So Jill Kuntz owned, with her brother and his wife, Brad and Tomo, who have since moved to Japan. They owned 3 heated yoga studios in Boston area. So it was Financial District, Harvard Square, Back Bay. And Jill and I became friends at the same time that David was telling me that he was going to help me research this. And what we did is we married the infrastructure of the DCRP, which was this rigorous clinical trials infrastructure. And we married that with the free yoga that was donated from the Kuntzes. And we had the students matriculate through the Boston area studios. So Brad and Tomo moved to Japan. Jill sold all her studios, but the Back Bay, she ran that for a while. They've changed ownership quite a bit. But right now, the only studio that remains is a studio in Harvard Square owned by Shelley Cates and Pablo Picker, and just putting their website up there. And there are studios all over the area. There's Burlington, Natick, there's many heated yoga studios in the area, but in the Boston area, and now Down Under Yoga has started doing heated yoga. That's a more recent thing though. So today I'm going to talk about yoga. This group probably doesn't need to know what yoga is, so I'll keep that brief. I'm going to cover the research on non-heated yoga, heated yoga, and whole body hyperthermia, present both of our original studies. So the first study 1 is the open label, study 2 is a randomized controlled trial, both of them heated yoga for depression. I'm going to go into depth on a case study just so we can kind of zoom in on one person and talk about that. That is what sometimes when we're writing grants, I'll sit there and think, am I actually doing this for anyone? Like, you just sort of feel like you're putting things into a void, and it's like, is this helping anybody? And there were a couple participants that got remarkably better, and we did 2 case reports. So I'm going to present one of those, but those help me sort of stay motivated sometimes when it feels like, what am I doing this for? And then I'm going to talk about what we're doing with whole body hyperthermia as well. So first, why would we study yoga? And I think, again, the community at Osher is probably well aware of this, but figuring out how and for whom does yoga, how does it work, and for whom does it work? And I think for one of the questions that I have right now is, clinically, I don't know of a study that compares heated to non-heated yoga for depression, and figuring out who might need the heat, who might not need the heat. That's a study we would love to do. We are trying to figure out how to do it and get it funded. For example, I have a lot of mentors that don't study heated yoga, that remind me how rigorous this is and how you wouldn't put somebody who's, say, elderly with a heart condition. There's bounds to this kind of yoga. Figuring out safety and efficacy, insurance reimbursement. So I think this is also an access issue. And, thinking about, if you could get insurance coverage for yoga, I think you could help integrate it into medical centers. You can make this more accessible to people who are under-resourced and may not, it's almost like food deserts. There's yoga deserts, I think, because, yoga studios are typically in more affluent areas. And I think there's a lot of issues inherent in that. In terms of being practical and feasible, one of the things that I love about yoga is that it's already existing. So you're not creating something new. It's already in existence. There's an infrastructure, and it's inexpensive relative to what the cost is to seeing a mental health professional. And that's not to say that people don't need to see a mental health professional. This is just something I think that exists that you can use to manage your own symptoms in addition to seeing a mental health professional, if that's something that you need. There's a positive focus, so you're not dealing with the stigma of the mental health system. You're also able, I always say that heated yoga, and I think it's about yoga too, packs a powerful punch. And what I mean by that is you're getting intensive exercise, you're getting the benefits of heat, and you're getting the benefits of yoga and mindfulness all in one time period. And I think there's, since it involves the body and it's a mind-body practice, you could think of Rob Saper's work, and you could think of the fact that he showed that a certain sequence of yoga postures was as effective for treating low back pain as PT. So you've got a patient that has, for example, low back pain, depressive symptoms, and maybe some stress reactivity. There's a study that shows heated yoga actually lowers stress reactivity in a Trier social stress test with cortisol levels. You could help them manage all of those things with one intervention. And I think that although it is time consuming, you're getting that mind body intervention in one package. The last thing is that I think a lot of times, like if you think of CBT or medication management in people with depression, it's symptom reduction. And we don't really talk about so then what, right? It's like, you want to reduce this suffering, but how do you, while you're reducing the suffering, you want to induce positive states. So I'm going to present the open label study, the study 1, I'm going to show the data in that way, thinking of it that way. But that's another reason I really like yoga as an intervention, in that it can kind of tip those scales. And you could think about that as nervous system, in the nervous system. And this is Chris Streeter's work, and others as well, where you look at heart rate variability and sort of thinking about sympathetic arousal and decreasing sympathetic arousal. And I think that could map onto treating the negative and sort of increasing the parasympathetic tone, which you could think about as inducing positive because you're in that rest and relaxation and able to enjoy things and actually connect socially. So I think, you know, it may sound a little woo-woo to say, you know, reduce suffering and increase positive consciousness states, but I do think it maps on to biological states of the body. And in terms of yoga, this is one way. There's so many practices in the United States. So you can think of them in these different domains. And you could think of the physical intensity of them, the focus on the spirituality, the temperature, the breath versus postures focus of the practice. And here's some common practices. So for example, if you take sky yoga, it's very breath-based. It's not in a heated room. It's not physically intense. If you take heated yoga, it's very physically intense. There is no spiritual focus in the dialogue, which was very intentional. It was done so it could be integrated with the religious views of America. That was what I was told, that was why it was. It's the hottest form of yoga that I know of. It's done in 105 degrees with at least 40% humidity. And it's 26 postures, 2 breath postures. So it's less breath focused, although you are breathing, unless you're told otherwise, you're always breathing in and out through the nose, which is supposedly supposed to activate the parasympathetic nervous system. I don't know anybody that studied that, but that's what the teachers always say. Anyhow, so what do we know about yoga and depression? This is a systematic review that was published in 2021. And they included 13 studies on depressive symptoms. And you can slice the research different ways, whether you include for studies that only do major depressive disorder versus depressive symptoms. This particularly meta-analysis included 13 studies, which is about the, you know, that seems to be the number. But I don't know that it's totally all inclusive. So they concluded a moderate effect of yoga on depressive symptoms compared to control groups. And they're saying the studies, you know, had fair to high quality. You can see that. This is from their article. And you can see down the line whether the different study, does it favor yoga or favor the control? For the most part, most of those boxes are to the left. So it favors the yoga over the control. So it seems like yoga, there's pretty good evidence that yoga is helping depressive symptoms. This was my own kind of quick and dirty way to explain it. And the reason I show this is to show some of the issues in the literature. So this is, again, this is yoga, randomized controlled trials, major depressive disorder. And if you look down the intervention line, you can see there is such a variability and heterogeneity in the interventions, which makes the literature a little bit, and not that everybody should be doing the same postures, I'm not suggesting that. Just this idea of like, what is an adequate dose, right? You're looking at what is a dose, what's the duration, the frequency, what kind of yoga do people recommend? It makes it a little murkier in terms of like, how do you prescribe this or think about the evidence base? Control conditions are tricky. David and I have written a bunch of grants, and the calls that we have, a lot of the calls are around control conditions. And the best control conditions, so Chris Streeter and Lisa Ubelacher are the two sort of established researchers for yoga and depression. Lisa uses a health education control. Chris both of whom are collaborators and mentors. Chris uses walking. The walking intervention has issues. It controls more for exercise, but then you're also getting the antidepressant effect of the walking, which has antidepressant effects. Lisa's intervention, the control she uses, both of these have been funded by RO1 NIH level RO1s. Lisa's intervention controls for time, group effects, and attention. You're not controlling for exercise. So it's just difficult, like how to figure out what control to use. And really the study that we want to do is a 4-square dismantling sort of yoga, no yoga, heat, no heat. But figuring out how to do that is tricky. But I think it gets around the control issue. Whether or not people allow adjunctive treatments, variability in that. And in terms of the efficacy, I would just go back, instead of using my line, I would just go back here and just say, most of the time, these studies favor yoga over control. So let's talk about heat. You notice that there's not a lot. None of these studies are heated yoga. There's one randomized controlled trial that is published that is not mine, that I'm going to present on heated yoga. But let me talk about heat first. And people are drawn to heat, you know, all over the world. So this is in Iceland. It's a geothermal lagoon in Iceland. I just think that picture is so beautiful. This is a spa in Montreal, a Nordic spa. This is a Korean tourmaline spa. It's just what we would think of as just a normal sauna. And what do we know about heat by itself? So the only randomized controlled trial that's rigorous and I know of is this study. And we are working with Charles or Chuck Raison, the last author who coordinated all these studies, the studies of whole body hyperthermia. He has an open label study as well. I'm just going to talk about the randomized controlled trial. This study was very interesting in that the effect sizes in this study were huge, and I will show you them in a moment. He randomized 34 people, 30 actually received the intervention. So they went into, let me skip ahead, this device, this Heckel whole body hyperthermia device, and the head sticks out. And the active condition, this is another, so in addition to the effect sizes, they had a very believable sham, which makes the effect sizes even that more impressive because it controlled for the placebo effect and expectancy effects. What he did for the active condition is he brought people up to 38.5, which was 101.3 degrees Fahrenheit. And he brings them up to temperature. It takes about 90 minutes. And then he has a 60-minute active cooling phase where they stay in the device for 60 minutes. And their temperature usually does go up a little bit. It's like a point, I don't want to say a degree because it's like a 0.1 of a degree. It goes up like 0.2 or 0.3 from 38.5. And that's during the cool down period. You turn off these major heaters over the chest during the cool down period, and you just leave the leg heaters on. So the sham condition, let me go back to this slide. It was matched for time, and you only put the leg coils on, and they had a contraption over the top where they had lights and a fan so they could simulate what it would feel like, you know, that people wouldn't know the difference. And there was a box they built around the heaters so you can't see what's going on. And in the sham condition, people actually got warm. And it turned into a low temperature condition. And part of the reason it turned into a low temperature condition is that, and I've heard him talk about this a lot because we've written some grants with him and we're trying to figure out a better way to do the sham so that it doesn't bring people's temperature up so much. And what he said is that MDD, and I know that when I say this, people look at me a little bit like I have three heads. He considers MDD to sometimes be a thermoregulatory disorder. And that's one of the reasons he thinks whole body hyperthermia works to intervene with depressive symptoms. And so what he said is he didn't account for the fact that people with MDD are poor at thermoregulatory cooling, meaning they're going to heat up. So people in the sham got hotter than he wanted them to. Anyhow, that makes this data even more impressive in my mind. So this is, they get the one session. The other thing to keep in mind is they had one session of whole body hyperthermia. The one session takes about 2.5 hours. So it's time intensive, but it is a one-time thing. You get effects for up to 6 weeks. So this is week 1 after his whole body hyperthermia intervention. And this is the effect size. In the top line is the sham, which really was a low temperature control. And then you've got the active condition down at the bottom. And these effect sizes, for people that don't know effect sizes in psychiatry, antidepressants, the meta-analysis of antidepressant effect sizes, it's about 0.3 to 0.4. These effect sizes are huge for psychiatry. So to me, I sort of look at this data and I was so excited. I had a K award to do heated yoga when this came out. And I was delighted. I saw this and I was so excited. And actually Greg Friccione connected us to Chuck Raison. And we've actually had this collaborative relationship. We've submitted about 3 grants together. And so that has been very exciting. But this, yeah, so this study, again, just looks at people with major depressive disorder and you're just isolating the heat. So then we think about heated yoga and you're taking heat and combining it with yoga. So in some ways, it's a little, there's 2 components going on, which I think is really why I'm pulled to doing this dismantling study. The form of heated yoga that's standardized and the only kind that I know of that's been studied in literature was formerly called Bikram yoga. Now it's really called like original heated yoga. And it's 26 postures, 2 breathing exercises. You can see them there on the right. And it's very standardized. So it's standardized in dialogue and the sequence is always the same. It's always supposed to be 90 minutes, though they've started to play with time to make it more feasible, which would, I think, help feasibility, but it's going to hurt with the standardization for clinical trials. So that's something we've been struggling with in terms of if you're doing the yoga not at the hospital, you're doing the yoga in the community, you got that variability with time because they're doing some 60 minutes, some 75, some 90-minute classes. But otherwise, it's still pretty standardized. And the Bikram yoga teachers will tell you it accommodates beginners because you can do, there's no flow. And the dialogue is created to get you in and out of postures safely. And you only go as far as you can. I think the accommodating beginners is probably questionable. I don't know that everybody would agree that this accommodates beginners. That's what the proponents of heated yoga will say. So just to put that on there. And I don't know of any, I actually didn't put our adverse events in this presentation, but I'm happy if anyone has questions, if you email me, I can talk about that. But I don't know of any studies that compare adverse events in heated versus non-heated yoga. That would be interesting. So this is the only RCT, a randomized controlled trial of heated yoga for depression. Ours is not published yet. So they beat us to it. This is a group in Canada. And this study compared heated yoga to an aerobic exercise control and like an attentional control. And what's interesting here, so they took 53 women, so only women, MDD. They found, and they asked them to go to the heated yoga twice a week, aerobic exercise twice a week, and both conditions outperformed the control, the attentional control. They had similar response rates. And let's see, you can also see huge effect size, 2.03 for the yoga group, the heated yoga group. This top line is the Hamilton scores pre and post, and you can see the yoga and the aerobic exercise, they go down significantly, at least half. Weightless control actually went up 2 points on the Hamilton. And then these are just their secondary outcomes. So that's what we know. And let me present, so on our original research. First study, open label, second study, randomized controlled trial. So our open label study was published in 2019, the Journal of Alternative and Complementary Medicine. It was 8 weeks, healthy adults. And if people are interested in the question and answer time, the inclusion criteria, we kept it pretty stringent. And David helped me a lot with this to figure out, this isn't just regular yoga. You're putting someone in 105 degrees. So we excluded for cardiac issues. We did EKGs. They all met with David before. In the randomized control trial, Darshan stepped in and was our medical monitor. So we were careful to try to, if somebody was questionable, we would check with their specialist if they had a cardiac specialist or something like that. We were also careful about medications that could be dehydrating, so lithium and stimulants we were very careful about. And we did the assessments in our program, and then the yoga was done in the community Bikram studios, which is, I like the generalizability of that it's already existing and it's in the community. However, we've been thinking about some mechanistic studies and sort of using hot yoga domes and bringing them into the lab so that we can have more control over the temperature, the standardization, and getting blood pre and post, because we're starting to realize that we need to get blood more tightly tied to the intervention, because I'm not presenting the biological findings. I'm happy to talk about them. Basically, we did not find anything with our inflammatory markers, and I can talk about why I think that is. Intervention, 90 minutes, 2 breathing exercises, 26 postures, and very hot in there. And we asked for at least twice weekly classes, and that's something to keep in mind throughout the data. You're going to see we did not get people to go to at least twice weekly classes. In the first study, they went to about 1 a week. Second class, they went to about 10 over 8 weeks. So it's like a little over 1 per week. And here's our consort chart. And you can look this box right here in the middle. It's a modified intent to treat. So what we decided is just include people who went to at least 1 class and subsequent assessment visit. So there's 28 people in this analysis. And here's our demographics. So sadly, a lot of the yoga literature, yoga users, there's literature on this, are typically in the US, and I think this is just privilege and access issues, and even kind of where the studios are, who's going to the studios. There's this stereotype that it's white, educated, young to middle-aged women. And I think, unfortunately, we had more women. It's predominantly white. People are well educated. So this is something to think about and focus on recruitment and targeting, getting more representation in these studies. As a group, I think, as a literature base, I think we need to do this. We're actually working on a study, a paper, a systematic review right now of yoga interventions for low income individuals, and trying to figure out what are the ways to get more of those individuals in studies. And then I think the broader implications are how to bring yoga to under-resourced populations. So in terms of the open label study, sadly, we did not have a good graphic in this paper. I just went back and I was looking at it and I was sad that I hadn't thought to chart this out better, but it worked. So when you do the analysis, this was our effect size, go back, 1.43, and it was significant for the clinician rated, the Hamilton's, the clinician rated depressive symptoms, and then the self-reported back depressive inventory, both of the effect sizes over 1, they were large, very large. And we looked at responders if they went to at least 3 weeks of yoga, just thinking that that's enough time to expect somebody to have a response. Of those 23 people, you can see we had 52% responders and then 57% remitters. And this was the attendance from that study. And if you look down, so right where it says 15 at the bottom, this is the total class attendance. We had a mean of about 8, which is 1 class a week, and we asked for at least 2. So people were not going as much as we thought, and it still worked, which is that's an interesting take-home message. And you can see we wanted people well above 15, and most of the people are well below 15. So I think we've thought a lot about adherence, and if we want to boost adherence or is once a week enough? And that's an interesting topic that I can talk about if people have questions. In terms of attendance, we found the Hamilton, so the clinician rated there was a trend for the more you go, the greater the reduction in depressive symptoms. The P was 0.063. So we published it saying a non-significant effect. So trend, however people want to think about that. But attendance was significantly associated with greater improvements in depression on the self-rated inventory, the back, you can see the p-value there. Now, I like to present this data. This was not published this way. This is the open label trial. I'm just showing it on 2 slides. So these are the negative domains and these were the positive domains. The reason I'm showing it this way is to think about yoga. In the beginning, we were talking about how it can reduce the negative and increase the positive sort of states of being. And this is just a way to think about that with the data that we have from that open label study. So it's reducing, here's your depression, hopelessness goes down non-significantly, anxiety, negative affect went down, and impairments in cognitive and physical functioning also went down. So you're seeing just this reduction in symptom burden across the board, and I would equate that like as a proxy for suffering, states of suffering. And then in terms of inducing positive states of consciousness, you've got optimism going up non-significantly, you've got quality of life improving, you've got self-compassion improving, and positive affect improving. So what we did is we took the pilot data that we had and we applied for funding for a K award for me, which we got. And this was our clinical trials page funded by the National Center for Complementary and Integrative Health. Very grateful for that funding. And we did a randomized control trial, heated yoga versus a weightless control. So we're going from that open label to just an attentional control. And our hypothesis was that it would work, that the yoga would outperform the waitlist. So we randomized to a heated yoga group for 8 weeks or an 8-week attentional control where they did the same assessments. And then after that 8-week period, they did the same yoga. And then we tracked them during that period. Both groups, I actually did this for all the 80 people. I did or however many people made it to the psychoeducation period. So either right before the active group started, so at their baseline, or at their re-baseline where they would start yoga after doing the 8-week waitlist, they would sit with me and do a preparation session, which I really recommend if anybody's doing research with this intervention, because there is this intensive acclimation period and there's things you can do to make that first class less painful, such as hydration, warning people about food, telling them what to wear. Some studios have mirrors, talking to them about mirrors, talking about any issues that might come up. So we did a 45-ish minute session with them, just talking about what to expect, how to breathe, sort of what the tone of the classes is going to be like, this concept of nose breathing, which took me 6 months to learn. Also sort of this idea that you're only supposed to go as far into the posture as you can, and then you stop, you don't push it because that's when you can get injured. So just going through some basic things that are helpful to know going into the practice, and that we created in collaboration with the studio owners to make sure that, we're not the experts in that. So that I highly recommend. I think that was helpful. I hope that was helpful for the participants. Outcome measures, we use the IDS, clinician graded scale, every 2 weeks during both arms. We gave the Hamilton as well. The reason we gave that is it has a scale in it for anxious depression, which I actually haven't analyzed yet, and I need to remember to do that. And we gave that at important time points, and that's why we have 2 rating scales for depression. Here's our consort chart. Essentially, when we did the same modified intent to treat, so they had to go to at least 1 intervention, yoga intervention, and subsequent assessment visit. For the active group, the waitlist group, they just had to go to the assessment visit to be in the primary analyses. And we haven't actually published the data or worked on publishing yet the data of the combined groups, but I will report on that for the attendance findings. So you can see we had about 55% of completion rate for the active group, 65% for the waitlist group. I think it's really interesting that waitlist group had greater completion rates. My hypothesis is that 1, they didn't have to jump into this rigorous thing. They got time to think about it and prepare for it, and or maybe get excited that they were doing it and have to wait. And that's why I'm thinking that maybe they hung in there a little bit, or maybe they felt more allegiance to us because they were in the study longer. I don't know, but that is a little bit higher in the wait list. And you can see the mean attendance is around 10 for both groups. So again, we asked for at least 2 a week, which would have been 16. So people are not going as often as we asked them to go. Here's just another picture of the attendance, just another way to think about the attendance. So this last bar was really what we were asking for, and most people were not going that often, which was what we found in that open label study as well. And here's the kind of meat of the study. So the primary outcome was IDS, and these are our IDS scores. And you can see the wait list is the blue line at the top, and the yoga group is the red line below. Our effect size was over 1, so we had a large effect size. Week 8 was our primary endpoint, and so it worked. So we proved the hypothesis, it worked. And again, I think the take-home message for me is it's working at a dose much lower, at almost half of what we thought we needed to prescribe. And I think there's part of me that's thinking, oh, let's boost adherence and get people in there and get their symptoms down even more. And then there's another part of me that's thinking, well, maybe once a week is enough, right? Maybe that's what this data is telling you. So that's something that we think about. And, there's also sort of this, Chris Streeter did a study, a dosing study on yoga, Hatha yoga, non-heated yoga for people with major depressive disorder. And it was 2 versus 3 times of Hatha yoga, or Iyengar yoga per week, which she found was interesting. And I think gets at this dosing question. Essentially, if you go to 3 times a week, your chances of having a BDI score below 10 are significantly higher than twice a week. But if you go twice a week, you do get a significant reduction, statistically significant reduction in depressive symptoms. So it's kind of like, maybe the more you go, the better you get, but maybe there's a point where it's just, what works with your schedule and what's feasible, and just encouraging just something, something's better than nothing, and works to reduce symptoms. So these are our response and remission rates from this study compared to the wait list at 8 weeks. So you can see 44% remission, 59% response, pretty similar to our open label study. And then for attendance, we did collapse across conditions, more frequent to get a larger sample size. So more frequent attendance was associated with a greater reduction in IDS over time. This is the study 1. You can remember there was a trend for the Hamilton, the clinician rated. I'm wondering if we just had more power to detect this relationship here. So it does seem, and in Chris's Streeter study, it seems to matter. I think dose matters, but this data has not been published. It's under review, the data for this study. And here are our secondary outcomes from this study. And you can just see across the board. So if you look at the secondary outcomes, you've got anxiety, you've got the Hamiltons in there, quality of life and perceived stress, they're all going down statistically significantly. In conclusion, with this randomized controls trial, we saw antidepressant effects with a large effect size. We did see attendance mattered. I think the strengths are that it's novel, that it's a randomized controlled trial. It was blinded. We used gold standard metrics. The biggest limitation in my mind is that we didn't use an active control, and we also didn't compare it to any standard treatment. So I think next would be replicating it with an active control. And I would love to study the sequence in with and without the heat. And then you start, that's a little complicated because I don't know if the sequence without the heat is actually enjoyable for people, because I've done it without the heat and I don't enjoy that sequence. So, and I've talked to a researcher, Stacy Hunter, did that study in Austin, Texas, and she had a hard time keeping people in the non-heated condition because they did not enjoy doing this sequence without the heat. So then you're thinking, is there like an equivalent yoga that you can compare it to that's not heated? And Chris Streeter did that with her walking condition. She compared, she made sure that the METs were all matched up, so the metabolic equivalents. So you're thinking, is there a way to do that? Anyhow, that's a study we'd like to do. Also, this dismantling study to look at the Foursquare, and you'd have yoga, no yoga, heat, no heat. But I think doing a 4-group study the power sounds overwhelming. So briefly, just to give you a case report from the randomized control trial to sort of zoom in, this is a woman who came in, she was getting ECT, and I was actually cursing myself when she came in because I hadn't thought of making it exclusionary. And I'm thinking to myself, this is not going to work. If ECT is not helping, I don't think heated yoga is going to help. Anyhow, she ended up getting better. She'd been depressed since 17, never fully responded to ECT. She'd had acute ECT. She was in maintenance ECT while in the study, on medications, on stable medications throughout the study. And we allowed stable medications in both of our studies. She still had a pretty big symptom burden, even though she was on polypharmacy. So she was on different, they were targeting different things with her medication. So Effexor, Wellbutrin, gabapentin there. And she was getting maintenance ECT and still had a really significant symptom burden. And you can see here, I'll go to the picture. She went to 12 of 16 classes. So keep that in mind, no adverse events. She was randomized to the wait list, diagnosed major depressive episode, melancholic features when I did the mini. And here's her data. So she in the wait list, and the one to really look at is the IDS, just because that was our primary outcome. So that's the solid line. So she starts the study with a 30, I think it was a 32. And then she gets rebaselined at a 20. So she went down significantly in the wait list. So there was a placebo or expectancy effect. So then she went from a 20 to a 3 when you added the heated yoga. And it remained. So you look at week 8 was our endpoint, and then she stopped going to yoga. I don't believe she did any yoga during the 1-month period. And you kept those symptoms stayed down. So this was just an impressive example of, wait a minute, could this work for treatment resistant folks when you actually add it to their treatment regimen? So I'm going to skip through the qualitative data just because I added it in this morning so I would have it, but I knew that I probably would not have time, and I want to leave time for questions. So I've got it in here if anybody is interested in hearing about it. And I'm going to talk a little bit about whole body hyperthermia. So these studies, I don't have my own data on. I work with a team. This is our internal team who's working on it with us at the DCRP. These are our wonderful research coordinators who make it all happen. They've been really incredible. And these are our external collaborators. And you can see the father of sort of whole body hyperthermia, Chuck, is right there. Tina is the regulatory guru who he works with. Chris Lowry is our inflammatory biomarker expert in Colorado, among other things he does. And Ashley Mason studies whole body hyperthermia at UCSF Osher and uses a sauna instead of the Heckle. So she gets around all the FDA regulatory hurdles, which is brilliant. And she has helped us a great deal. And we've just started working with her more recently, but very excited to be collaborating with her. So we have 2 studies going on right now. One is Simi Foster's K23 award through NIGMS. She's going to replicate Chuck's randomized control trial with a larger sample. And she is a molecular her PhD is in molecular biology. So And I'm probably not even going to do justice at explaining this, but essentially she's looking at inflammatory signaling and the cellular heat response and how that's contributing to the antidepressant effect of whole body hyperthermia. And Chuck and Chris do have data on the inflammatory markers from whole body hyperthermia, and I'm happy to talk a little bit about that. That data is not yet published, but I can talk about it. I have permission to talk about it. And then here's Simi Foster's. This is it. Actually, we are starting to enroll like next week, and here's our email. So if anybody's interested, this is the email. I can put that in the chat at the end so people have that, but we're starting, which is very exciting. And then the last thing I want to talk about is we were fortunate enough to be funded by the Osher pilot research grant funding mechanism for a study of long COVID. And we're going to be using Ashley Mason's sauna device, and we are going to see if whole body hyperthermia helps long COVID. And we have some data. We have data on one individual that we think it helps. And we also, it helps with chronic fatigue. It helps with fibromyalgia. It helps with Lyme, helps with depression. We think that and it helps with inflammation. So we have some reason to think that it's going to help with long COVID. And I really do, I hope that it helps, but we have not started that yet. That's being sent to the IRB, hopefully this week. And we are using, I have one on right now, Aura Rings, and Ashley Mason has donated this to us from her. She had a large scale study to look at predictors of predicting people who get COVID with using Aura Rings. So she had some Aura Rings that she has we're on loan. So we're going to use these in our long COVID study, and we're going to look at inflammatory markers. I'm very excited to do all that work, which we have not yet started. And I think that's it. Thank you all so much for your attention. I really appreciate it.
Thank you, Maren. What a really spectacular presentation and really exciting. If you want to just unshare for a moment, and
Sure.
And then great. And Emma, if you can just spotlight there. Let me just, there are a couple of questions that came up, and just, I'll kind of synthesize a few of them. But one, and I know you alluded to this, but did you experience any adverse events in your study, or have there been adverse events reported in the scientific literature, particularly around heated yoga, that are uniquely different to heated yoga compared to, say, adverse events that are reported in yoga literature in general?
That is a great question. So I think obviously the heat, you get adverse events from the heat. So in our study, we had dizziness, nausea. One person was vomiting after every class, and they kept wanting to do the intervention. To me, that was kind of a like, okay, do you want to stop? But they actually kept going to the intervention. We didn't have any, I'm just looking, I have my primary paper up right now. And I can share the adverse events that we had. And let me share. So this is not published yet. This is out for review, but there were 3 mild adverse events, 3 moderate adverse events, chills, nausea, dizziness, vertigo, back pain. I think the chills, nausea, dizziness is very specific to heated yoga. The vomiting specific to heated yoga, or maybe she wasn't vomiting, maybe she was gagging. And she kept we'd ask her how distressed she was by it, and she was not that distressed by it. So I do think there's very specific adverse events related to the heat. And I was very grateful that we didn't have any serious adverse events, because I think it's easy to, like, I took my brother to a class and he went too fast and the room was really hot and he wasn't hydrated and he passed out. So there are, and that's why we had so many medical exclusions, and we were being really careful about medications. We were trying to have an abundance of caution, just because it's 105 degrees and you're asking somebody to bring up their heart rate.
Second question was just thinking about the protocol itself. And you mentioned it was 26 postures, 90 minutes. Did the intervention include any meditation components as a part of those postures, and either during the session or any deep relaxation at the end of the session in addition to sort of the active movement from one posture to the next.
Let me see, I'm going to bring back up that slide. So what's this form of yoga, they claim, I'm trying to bring back up the slide. They claim that it's a 90-minute moving meditation is what the teachers will say while they're doing the intervention. Just show the slide again. Between when you get to the floor, so posture 13, you are doing 20 minutes of savasana, which is like, people probably know what savasana is, just it's a resting pose between each of the postures. And you do each posture twice. So there's quite a bit of savasana between each of the poses on the floor. And then at the end, after 26, you do 2 minutes on the ground where you're kind of in a meditative state, and the teacher is trying to keep you there for at least 2 minutes and encouraging you to stay longer. So a lot of people, what I've noticed just anecdotally, the people who practice a lot, they're on the ground for 10 to 15 minutes after a class. And, you know, the Jill Kuntz, I talked to her a lot about like the practice and things like that. She's saying a good heated yoga teacher, they're operational commands and they're definitive and they're short, and they get your mind, they get you out of your mind and they get your body just sort of responding to the command. And she's saying that that's sort of they're putting you into this kind of trance-like state. And then that the whole thing would be a moving meditation. And I know when you look into meditation research, there's so many different kinds of meditation. There's like, you know, so and I'm not an expert on meditation. So there is a mindfulness component for sure, but they're not talking to you, you know, they're talking to you about rest when you're in the savasana. And different teachers will say different things, but they're not like harping or they're not focused on the mindfulness part of it as much. They say to me that you get the mindfulness benefits just by doing it. It's like they want people to sort of do it and do it well and get the mindfulness like as they're going and going through the more rigid the structured sequence.
Okay. In terms of so how many of the individuals the 60% who responded well were beginners to yoga versus advanced practitioners?
That is a great question. So to get into the study, they couldn't have done heated yoga for, I think it was 6 months. They couldn't do more than 6 classes. And there was maybe 1 or 2 people who had been like practiced a fair amount before they came into the study. Majority of people had either never done it or done it like a handful of times. So it was mostly novices, which every time I go and haven't been in a while, I am always humbled thinking about people with depression going. It's a very intense thing to get into. And that's why we did that psychoeducational session, is to try to, it's just, there's a real steep curve into acclimating to the environment. And it's uncomfortable. It's not a comfortable thing in the beginning.
In terms of the heat, do you think you know is there a difference you know if you're doing it at say 95 degrees or 90 degrees versus, I mean, which is still hot for many of us, versus the 105? How do you hypothesize there?
That is a great question. So I have done it with when heaters have broken, and I've done it in Down Under Yoga in Harvard Square. Their heaters are not fully up and running yet, so it's about 90, 95 in the rooms. I do not get the same benefit. When there's no heat, I do not enjoy it. It feels cold and I don't enjoy the sequence. I've done it at home, like in COVID without heat. I don't enjoy it. If it's in the 90s, it's better than no heat. But for me, I've like gotten accustomed to that feeling. And there's something that I get from the experience, which I think goes back to the meditation question, which is there's a ringing out that I experience. And a lot of people that do this kind of yoga will tell you that you get this sort of ringing out of your whole system that lends itself to then you're sort of, you know, I know yoga sort of was meant to prepare the body to meditate, you know, so I think for me, the heat is part of that. And I know that a lot of people who like non-heated yoga would take issue with that and don't need the heat. And I think that's part of what we need to study. Like, I think I probably have a more revved, agitated way about me. And I always say this to David, so maybe it works for the person that needs that intensity to sort of match their own intensity, and other people don't need it, and they don't need it to be that hot. I don't know if everybody needs that 105 degrees. I do think Chuck's Raison study shows, and the temperatures that he gets people up to are similar to what people get up to in Bikram yoga. In that 105, there's an IL-6 burst right after the class. And they did a study of heated yoga in and not in the heat, and people without MDD. And you only get that IL-6 burst right after the class with the heat. And what Chuck and Chris and those folks are hypothesizing is that IL-6 burst, that IL-6 can be, you think about it as inflammatory and negative, but they're saying it's pleiotropic, so it can actually be good, and it can signal an anti-inflammatory cascade. So they think what's actually happening is the heat is turning on this IL-6 signaling, and it's signaling all these anti-inflammatory cytokines. And that's what Dr. Simi Foster is looking at right now. That's what we're trying to study. But I think the heat may be necessary to get that anti-inflammatory response, but I don't know, right? Like Lisa Ubelacher published a study showing that IL-6 reduced in her study of not heated yoga. And I didn't get an IL-6 reduction long-term in heated yoga. So I think that's a great question, because I think a lot of people just aren't going to enjoy the intensity of that heat. And maybe they could do it in 95 degrees and get great benefit.
Okay. All right. If you can just unshare, I just wanted to first of all, thank you, Maren, for a wonderful. There are several other questions on the mechanism, thinking about breathing patterns, thinking about what is the active ingredient of yoga. Obviously, I know these are sort of a mechanistic model, as you even think about the sequence of postures. And then there was a question also about the case study they presented as well, in terms of just what happened with it. But I would encourage people to reach out directly to Maren for further questions if they want to. So again, thank you for a wonderful presentation, and really excited to see how this story unfolds, because obviously there was a lot of popular craze around heated yoga, and obviously what was formerly known as Bikram yoga, but it did change sort of a landscape of how we thought about yoga in a very different way. And so it'll be interesting to see how all of this whole research continues to kind of come to life. So thank you for the work you're doing. And let me just remind everyone, I just wanted to share again, to have this discussion and much more at our upcoming Integrative Medicine Network Forum next week, November 10th and 11th. Please register. It's free. We're going to be talking about, Maren will be presenting there as well, along with many other luminaries, and thinking about sort of the cutting edge of depression management, sort of out of the box thinking. In addition, we'll also be looking at just how the lens by which we view depression through an interfaith perspective, cross-cultural perspectives, obviously through research perspectives. And then finally, we want to also have the patient perspective as well, which will be there as well. So this is really an exciting 2-day meeting. It's free. And it's, as you can see, really, we have a lot of support from different entities across our local system, but also nationally as well. So I look forward to having you there. I think the registration link is in the chat for all of you to just click on and register. So we will then see you next for Grand Rounds on Tuesday, December 6th, which will be the Kogan lecture in honor of Jack Kogan. It'll be the second annual Kogan lecture, and our keynote there will be Dr. David Rakel, who will, the chair of family medicine at University of Wisconsin-Madison, talking about in terms of our thoughts about what does it mean to really be healthy, and how do we focus on that in our system, doing more, taking less, and living longer. So thank you. We'll see you next time.
Thank you.